Hi, this is going to be a fun one, I think. Chemoreceptor reflexes. We've talked a little bit about carotid sinus, carotid body, aortic body, that sort of thing before, but I want to do this from a functional anatomy perspective in that we're talking about the regulation of breathing here, right? I want to talk about the sensory structures, the sensory nerves and their pathway, where they go to in the brainstem, look at the actual reflexes going on in the brainstem, kind of lightly, and then the motor output and how that affects breathing. Now, because we're talking about breathing, whilst I might try and pretend that this is functional anatomy, I think I'm going to be straying outside of my box into physiology because I'm an anatomist. But as long as you don't tell anybody, I won't tell anybody, and the physiologists will not even know that I've been on their turf. Ventilation is a very interesting idea anatomically, neuroscientifically, neuroanatomically, physiologically, and it always grasps students. I've been talking about lungs this week with students, which is why it's on my mind, because clearly the muscles we use for breathing, for ventilation, are skeletal muscles under somatic control. We can choose to move them, but most of the time we don't have to think about it and we just breathe in and out. And even when we're asleep, we keep breathing in and out. And there is a central pattern generator in the brainstem, which is a central generator generating this pattern, as in it's driving these muscles to breathe in and out. That's the crux of it, is that there's an autonomic process that causes the diaphragm to move, the intercostal muscles to resist the changes in pressure inside the thorax, and even to move the ribs themselves if they need to. But of course, we fine-tune that. Well, I'm talking about our brain stems, fine-tune that because we use oxygen. So ventilation is about bringing air into the lungs and moving gases between the air and the blood. Oxygen in, CO2 out. CO2 is a product of cellular respiration, right? So when we do more cellular respiration, we run up a flight of stairs, we go for a jog, whatever, you're making more CO2. You need more O2 as well, but then you need to adjust how deeply you ventilate and how often you ventilate to move more air in and out of your lungs per minute, right? To finely balance and keep the amount of CO2 and O2 in your body within certain parameters, right? And that's what we're talking about with the chemoreceptor reflex, although it does also have an effect on the heart because all of this is linked. Chemoreceptors are the sensory organs responsible for collecting information about oxygen, CO2, and pH in the blood and informing the brainstem about that. So they're the sensory apparatus. We find these chemoreceptors in the aortic arch, as the aortic body, and up here where the common carotid artery bifurcates into external and internal carotid arteries. There we find the carotid body. These are peripheral chemoreceptors. This is very clever, right? This is sampling the blood that's going to the brain, and then in the brain stem, and possibly elsewhere, possibly in the midbrain and the cerebellum, there are central chemoreceptors. Now, there's something we need to think about here. CO2 in the blood, it's largely carried around in the blood as bicarbonate, HCO3 minus an ion, and hydrogen ions. So bicarbonate ions and hydrogen ions. Now, hydrogen ions are responsible for the pH of a solution, right? It's the amount of hydrogen ions in a solution, pH. So if there is a lot of CO2 in the blood as bicarbonate ions and hydrogen ions, that means there are a lot of hydrogen ions, which means the pH is low, that the blood is acidic, right? Which means that these chemoreceptors could look at the pH of the blood. They could look at CO2 more directly, and they could look at O2 more directly. And in fact, how these chemoreceptors measure the amount of O2 bound up to hemoglobin in the blood, it's not entirely agreed upon. So some of this is still developing, right? As in our understanding of it is still developing. But chemoreceptors can either sense the partial pressure of oxygen, the partial pressure of CO2, or the pH of the blood. Now, it seems to be that the cells, the chemoreceptors of the carotid body, these are type 1 cells, they're neuronal-based cells. They trigger action potentials as part of their sensing process. They can sense O2, CO2, and pH. So they can sample oxygen, carbon dioxide, and the pH of the blood. The carotid sinus is also here, which is full of baroreceptors, which is detecting the blood pressure at this point. And these peripheral chemoreceptors seem to be quicker at reacting to changes in, say, the partial pressure of CO2 in the blood than the central chemoreceptors, but they max out sooner. So the central chemoreceptors are able to adapt actually to pH changes in the blood. They're able to adapt more slowly, but more fully to changes in the blood. The afferent nerve, the sensory nerve from the carotid body, is the glossopharyngeal nerve, cranial nerve 9. And that's the afferent limb of the reflex. That's carrying sensory information back up to the brainstem. Okay? Now, the aortic body, let me swap you out for an actual aortic arch that we can see. Lung. Whoop. There's the heart. There's the aortic arch. The aortic body can sense the partial pressure of oxygen, the partial pressure of carbon dioxide, but not pH, possibly. And the afferent nerve of the aortic body is the vagus nerve that we see here. So the vagus nerve, it loops around the aorta to get to the esophagus, right? So it's already right here. So the vagus nerve will then run up here with the common carotid artery and the internal jugular vein and run up the neck back towards the brainstem, right? The vagus nerve is cranial nerve 10. So the vagus nerve and the glossopharyngeal nerves, cranial nerves 9 and 10, they are the sensory limbs, the afferent limbs of this chemoreceptor reflex. And they will pass into the skull through the jugular foramen, right? So they're going to be running up here. And then once they've passed through the jugular foramen, they will be inside the cranial cavity, right next to the brainstem. And there's the brainstem. They will enter the medulla oblongata. And of course, we number the cranial nerves pretty much in sequential order from superior to inferior. So they're entering the medulla oblongata down there. Now, in the medulla oblongata, this is where we also find central chemoreceptors. The central chemoreceptors in the medulla oblongata are described as being found in ventrolateral areas of the medulla. And these central chemoreceptors are sampling really the interstitial fluids of the brain, right? Remember, we've got a blood-brain barrier and whatnot. And they are able to sense pH, react to changes in the pH of the fluid. And they don't directly sense CO2 or O2. They don't directly sense carbon dioxide or oxygen. So they will infer levels of carbon dioxide by measuring the pH of the blood, by looking at the number of hydrogen ions in the blood, or the concentration of hydrogen ions in the blood, rather. But it turns out that there are probably also central chemoreceptors dotted around the pons, the midbrain, the cerebellum. Elsewhere, we'll probably find them in the future, right? So the sensory parts of the chemoreflex through fibers within the glossopharyngeal nerve, the vagus nerve, and from the central chemoreceptors, they all run to the solitary nucleus, or nucleus solitarius. The solitary nucleus is actually, well, it also gets called the tract of the solitary nucleus. The solitary nucleus is really a collection of sensory nuclei running in a column through the pons and the medulla. So we've got lots of sensory inputs coming into the solitary nucleus, and they project out to various other things, such as the respiratory centers in the brainstem. And whilst there is a central pattern generator in here that is driving the patterns of inhalation and exhalation, there are a couple of centers in the pons. The pneumotaxic center, which can adjust the rate of ventilation, that can make you breathe in and out faster and more deeply, and the apneustic center, which will also drive inhalation. So the pneumotaxic and apneustic centers in the pons link to, in the medulla oblongata, a dorsal respiratory group of nuclei and a ventral respiratory group of nuclei. And it's that dorsal respiratory group that are responsible for driving the movements of the diaphragm and the external intercostal muscles for inhalation, and driving that pattern of inhalation and exhalation. So inhalation, the diaphragm pulls down and it flattens, the external intercostal muscles pull outwards a little way, maybe if you need to breathe that deeply. But then a lot of exhalation is just the elastic recoil of the lungs and the diaphragm relaxing, right? If you're not breathing too deeply. So the dorsal respiratory group will cause the diaphragm, the external intercostal muscles to contract. So you inhale, and then to relax, you exhale. Now the ventral respiratory group will tie into the internal intercostal muscles, which help you push air out, and to accessory muscles of ventilation. So if the dorsal respiratory group is tied into muscles for easy breathing, for normal ventilation, then the ventral respiratory group are tied into muscles that you can use for forced ventilation, when you need to push air out and pull air in, so that you can ventilate more rapidly, so that you can exchange a greater volume of air per minute, right? That means that the dorsal ventral group will have an effect on upper motor neurons, which are going to run down the spinal cord to the lower motor neurons of the phrenic nerve. The phrenic nerve innervates the diaphragm, right? C3, 4, 5 keeps the diaphragm alive. And also to intercostal nerves that are going to run to the intercostal muscles. The external intercostal muscles between the ribs will take part in inspiration, and the internal and innermost intercostal muscles will take part in expiration, and the intercostal nerves of what? T1 to T11 will innervate those muscle layers. Remember that these intercostal muscles always have tone anyway, because they're forming the wall of the chest. They're resisting the pressure changes being made by the diaphragm. The diaphragm is responsible for about 80% of the work done during ventilation. So those are the efferent nerves, the motor nerves. Don't worry, we're going to put all this together in a minute. But here is the phrenic nerve here. So the phrenic nerve comes out of the cervical level of the spinal cord and forms, and then runs anteriorly on the anterior scalene muscle, and it'll run posterior to the subclavian vein to enter into the thorax, and it'll run down with the pericardium around the heart to the diaphragm. And the same, oh, there we go, we can see it on the other side. There's the other phrenic nerve there, right? So the phrenic nerves will then drive the movements of the diaphragm. So That's the motor part of the reflex. The intercostal nerves are here. These are the intercostal nerves coming out of the spinal cord, and you can see them running with the intercostal muscles there. Okay, let's link all that together as an example, yes? One more fun thing while we're talking about reflexes. Stretch receptor reflexes, the Herring-Breuer reflex. So there are stretch receptors in the lungs, and when you inflate the lungs, they fire to tell the brainstem that the lungs are inflated. And when they're deflated, the lack of firing, I guess, also tells the brainstem that the lungs are deflated, and that triggers the change between inspiration and expiration, and inspiration and expiration. So that's part of this process as well. Breathing's complicated, but it's fun. Anyway, back to our chemoreceptor reflex. You're sat comfortably at your desk, breathing lightly, and diaphragm's moving in and out, and not much is going on, and the partial pressure of oxygen in your blood is just right, the partial pressure of CO2 in your blood is just right, and the pH is just where your body wants it to be. And you decide to run out of your room and up a few flights of stairs. Okay, so you have increased cellular respiration in your body, and those cells have now put out a whole load of CO2 into your blood, for example. So the partial pressure of CO2 is increasing. And as I mentioned before, a lot of the CO2, a lot of the carbon dioxide in the blood is in the blood as bicarbonate ions and hydrogen ions. So the proportion of hydrogen ions increases, the pH decreases. So first of all, your peripheral chemoreceptors in the aortic body and the carotid body detect these changes, either increasing levels of the increasing partial pressure of carbon dioxide or the decreasing pH, depending upon what they're able to do. And the aortic body will send that information through the vagus nerve back to the nucleus solitarius, the solitary nucleus. The glossopharyngeal nerve will also send that information back from the carotid body back to the solitary nucleus. And then a little while later, we're talking seconds, not minutes, the central chemoreceptors will respond to the change in pH and also send that information to the solitary nucleus. Fibers from those sensory inputs will project to the respiratory centers. The apneustic center, or probably more importantly, the pneumotaxic center in the pons will receive that information and will drive a faster rate of ventilation and deeper ventilations. So you breathe faster and you take deeper breaths by sending that information, first of all, probably to the dorsal respiratory group, which will drive the diaphragm to pull down further, so increasing the volume in the thorax, and probably trigger the external intercostal muscles that you weren't really using when you were sat down to contract, so that they increase the volume inside the thorax more with each inspiration. And then once you've run up many flights of stairs and you need even more air, they'll trigger the ventral respiratory group to also tell the internal intercostal muscles to help push the air out, so the rate of ventilation can increase even further, and maybe even add on some other accessory muscles of ventilation. So you're not just breathing in and then using the elastic recoil of the lungs for the air to leave your chest, but you're pulling air in, you're pushing air out. So the way they've done that then is the dorsal respiratory group and the ventral respiratory group have interacted with motor neurons in the spinal cord, which trigger lower motor neurons of the phrenic nerve to change those movements of the diaphragm, to make the diaphragm move more rapidly and further, and to the also to the lower motor neurons of the intercostal nerves that are running out to the intercostal muscles to change their activity as well. So that's the reflex. You get to the top of those flights of stairs. We've all experienced this. You're now breathing in and out quite hard, but you've stopped running up a flight of stairs. So your cellular respiration starts to drop. That ventilation rate is clearing the CO2 from your body. So the partial pressure of CO2 starts to drop, the pH starts to return to normal levels. Again, the chemoreceptors carry that information back to the respiratory centers in the brainstem, and the brainstem adapts again to change those movements so that you start to breathe more slowly, you don't breathe so deeply, and efficient respiration, efficient ventilation is restored for the level of activity. That is, you stood at the top of the flight of stairs doing whatever you're going to do next. The chemoreceptors are the sensors. The afferent nerves are the vagus and the glossopharyngeal and those central chemoreceptors' own fibers. The reflex happens in the respiratory groups, the respiratory centers of the brainstem, the apneustic and pneumotaxic groups in the pons, the dorsal respiratory group and the ventral respiratory group in the medulla, which then drive the motor neurons, the efferent neurons, to the phrenic nerve and the intercostal nerves, to trigger those skeletal muscles to move more, so that you can move more air in and out. That's the reflex. It also has an effect on the heart. My example there focused on carbon dioxide in the blood. So high carbon dioxide triggered those changes. The same changes would be triggered through that chemoreceptor reflex by a low partial pressure of oxygen, so hypoxia, and by and a decreasing pH, acidosis. The opposite response would be triggered by an increasing pH, alkalosis, right? And the opposite response would then be the slowing of your breathing, so smaller breaths, less often, and the ventilation rate, the amount of gas moving in and out of your lungs per minute, would be decreased with alkalosis, with that increasing pH in your blood. Does that make sense? Because that is a useful clinical fact, right? What about the chemoreceptor reflex and its effect on the heart? Right. Hypoxia. So if the body has low oxygen levels, is hypoxic, then the peripheral chemoreceptors will detect that. And the vagus nerve and the glossopharyngeal nerve, the afferent limb of this reflex, will take that information back to the solitary nucleus. And there are links to the nucleus ambiguous, which ties into the parasympathetic fibers of the vagus nerve. Okay, what happens when the body is experiencing low levels of oxygen is that the body reduces the heart rate and causes vasoconstriction of blood vessels elsewhere in the body to conserve the available oxygen for the tissues that most need it, right? So that sensory information comes in from the chemoreceptors, low oxygen in the blood. Solitary nucleus, nucleus ambiguous, triggers the parasympathetic fibers of the vagus nerve that run to the heart to reduce the heart rate. And they also tie into the sympathetic nervous system, which then triggers vasoconstriction of smooth muscle in blood vessels in parts of the body. So the chemoreceptor reflex, in terms of the heart, is low oxygen, slows the heart rate, vasoconstriction. Now, if that's the primary response, if you're in an environment where you have access to oxygen, as in air, right? You're not in a hypoxic environment. Well, if there's oxygen, if there's air to breathe, if there's oxygen available, if you're able to breathe, this will also trigger through the chemoreceptor reflex to the lungs for you to breathe more deeply and more often, right? That was the first bit that we talked about. So if you are breathing more deeply and faster, that will actually pull more blood through the lungs. So there's more blood flowing to the lungs and more blood flowing from the lungs to the heart. Oh, right, well, if there's more blood going to the heart, then there's more blood flowing through the heart. So for more blood to flow through the heart, it either has to increase its heart rate or increases stroke volume, or both, right? So while the primary response might be to reduce the heart rate, if you start breathing fast and breathing deeply, that will cause the heart rate to increase. So that the overall effect might be minimal. Heart, lungs, blood pressure, oxygen, carbon dioxide. Yeah, okay, I've strayed out of my box, haven't I? I'm in physiology land now. Okay, there's quite a lot there. The problem with talking about brainstem nuclei is it's a bit imaginary, right? Even if I draw a picture with ovals on it, I'm not sure that helps much. But that's the reflex. By understanding the normal reflex, you can understand, hopefully, the effects on ventilation, its rate and its depth when things are not working normally. You can see how the chemoreceptor reflex gives you clues to the partial pressure of oxygen, the partial pressure of carbon dioxide, and the pH of the patient's tissues and blood, right? This is all useful diagnostic stuff. And I know I harp on about the brainstem, but you can see how the brainstem is absolutely crucial. So damage to the brainstem through trauma, through ischemia, through a tumor, could damage these centers of respiration, which might damage these reflexes, or might just make breathing impossible. And this is why the brainstem is vital for life. And if the brainstem is dead, we are dead. Oh, what a happy note to end on. Whew, right, chemoreceptor reflex. I hope that was useful. See you next week.